Good afternoon and evening, everybody, and thank you for sticking with us. We're doing well. We're now on the top-rated oral abstract session. We have 3 speakers who submitted abstracts and have been selected by our eminent panel. We have each abstract is reviewed by 3 different people, all of whom are well-respected researchers and in the adherence field. And the 3 abstracts that score the best are invited to come in and share their work with us orally at this abstract session. And I think this year it's a special treat because we actually aren't hearing a lot of abstracts. So we're really pleased to be able to hear from some of the people who support our conference every year. We have 3 speakers. I'll introduce them one at a time. We're going to start with Mark van den Elsoot, who's a medical doctor at the Centre of Sexual Health and the Public Health Service of Amsterdam and has been there since 2017. He is a PhD candidate and his PhD topic is on PrEP in the service that he is in, and he's going to be talking to us a bit about some of the work he's been working on there. Can you share your screen, Mark?
I thought it was already sharing.
There we go. Nope, you've opened up. That's it. Oh, now it's gone again.
Oh.
I'm not going to be much use to you because I haven't had to share a screen yet today. But it is a...
Is it back now?
Yes, there it is.
Very good. Thank you so much for the nice introduction and for allowing me to share our results here this evening. At least it's evening for me here in Amsterdam. I'm going to tell you something about research we did on finding some predictors of PrEP adherence among men who have sex with men in Amsterdam, in the Netherlands. Well, as we all know, PrEP is really good at preventing HIV, but adherence is often key in helping that effectiveness reach its level that we most desire. And therefore, we did a randomized clinical trial here in Amsterdam to see if we could improve this adherence by giving people feedback on their self-reported PrEP use and sexual behavior. And today I'll be sharing some other results that we found in this RCT that can tell us something about how we can predict someone to be more or less adherent to PrEP, as well as some results from the RCT itself. In Amsterdam, we have the MPrEP cohort, as was already said in the introduction, which is the first Dutch PrEP cohort that started in 2015, and it's currently still ongoing. And within this cohort, we nested an RCT to see if we could improve the adherence. And MPrEP participants were eligible to participate in this RCT if they were daily PrEP users, because MPrEP participants could also choose to use PrEP event-driven. They also had to be able to use and willing to use the application on their phone and provide additional blood samples for the dried blood spot analyses. And the eligible participants were randomized 1-to-1 to either a basic app or a more extended application. And both applications allowed reporting of sexual behavior and medication use on a daily basis. And people were included at a 3rd, 6th, or 9-month study visit. Participants that were randomized to the extended application, apart from being able to report on a daily basis their sexual behavior and their medication use, also received visualized feedback on their input, as you can see on the picture on the right. What they could see was their trends in their pill use and their number of sex partners, and also what proportion of days of the month they had used their medication, and whether they had used PrEP in combination with a condom, or just PrEP, or just a condom, or neither. And also they received access to a more advanced alarm clock to remind them of their medication use. We collected the dried blood spot samples after 1 year and after 2 years, and also after 4 years, but those results are not yet included in these analyses. And we categorized them according to previous literature on the level of good adherence, from which we believe that the protection is good enough. So it was also discussed in a previous talk today, and also at excellent adherence, which represents consequent daily medication use. The outcomes from the randomized trial were primarily good adherence at both time points measured, and secondarily excellent adherence at both time points, and the overall medication level on a continuous scale. And also, we looked at the factors associated with adherence, which is clinically more interesting today, I think. And from all of our cohort members, with any follow-up, 351 we eventually assessed for eligibility, and 229 of them were randomized. The ones who were not randomized mostly were event-driven PrEP users, and because of the dried blood spot analyses, we could not use their results, so they were excluded. And from the randomized participants, everyone received their allocated intervention, and in the per protocol analyses, people were included who completed all their study visits and kept on using daily PrEP. So if they switched to event-driven PrEP, they were also excluded from the per protocol analyses. We also assessed whether the app was actually used and was acceptable to the participants. And we were quite surprised by the results of this, because we didn't motivate them to use the application. We just gave it to them at the start and see if they used it or not, to make it comparable to a real-world setting. And after 1 year, almost half of participants still use the app at least 5 days per week. And after 2 years, this was 41%. And on a 7-point Likert scale, the app was found to be very useful, pleasant, and easy to use. So that was nice to know. And if we look at the categorized adherence, categorized in poor, good, and excellent between the two different apps, what stands out, I think, is that the poor adherence levels are really low in both groups. So in the basic app, it's only about 11%, and in the extended app, almost 16% that was poorly adherent. And poorly adherent means that they were either at 12 months or at 24 months or at both time points less than good adherence in the dried blood spots. And if we look at excellent adherence levels, we do see a difference actually between the two applications. We see that in the extended app group, almost half of participants was excellently adherent at both time points, which means they were taking that pill every day consequently at both time points measured, which was a larger proportion than in the basic app group. And yeah, this is a bit of a complicated picture, but what I want you to focus on here is that this green solid line is the demarcation line for good adherence. So in this cohort, we are looking at a group of people that are really highly adherent, so might not be representable for PrEP users all over the world, because almost everyone, the vast majority, is really adherent at both time points in both of the allocations. Then, as I promised, the factors associated with adherence. First, some results from the multivariable linear regression model. Well, the application, as mentioned before, was found to be associated with higher adherence, but also older age, identifying as not exclusively homosexual, and a higher concern for acquiring HIV were found to be associated with higher levels of tenofovir in dried blood spots. And if we look at the multivariable logistic regression model with the outcome of poor adherence, we see that people who show signs of depression and or anxiety have a higher odds of poor adherence, as well as people, again, with a lower concern for acquiring HIV. And we also did this model with the outcome of excellent adherence. And here we found that people who were reported to be engaging in chemsex showed higher odds of less than excellent adherence. And chemsex was defined as the specific intention to combine sex with chemical drugs. In conclusion, our cohort are people of highly adherent PrEP users in general, and we did not find that the visualized feedback via the application increased the proportion of participants with good adherence, but it did with excellent adherence and yielded general higher levels of tenofovir in the dried blood spots. And characteristics we identified associated with higher adherence for older age, not identifying as exclusively homosexual, and a higher concern for acquiring HIV. And possible barriers for adherence were signs of depression, anxiety, lower concern for acquiring HIV, and engaging in chemsex. Which gives us the following opportunities for preventing ongoing HIV transmission within the scope of PrEP users. And I think we can pay extra attention to these potential poor adherers by targeting them during the counseling sessions, especially if they belong to one of these groups, the younger PrEP users, as was also mentioned before in the talk about the persistence of PrEP use, but also people showing signs of depression and anxiety and showing a lower concern for acquiring HIV. And I think if you also have the idea that people could use extra help, for example, if they could have an anxiety disorder or depression disorder, or experience problems with their engagement in chemsex, people should be referred to specialists to resolve those problems. And also something that would be interesting is to focus on populations with lower baseline adherence levels than that our population had. That was what I wanted to share with you tonight. I'd like to thank all our participants and my co-authors and my study team.
Thank you, Mark. I'm afraid we can't really have...
I think you're still muted, Catherine.
Oh, I thought I'd unmuted. I'll say sorry. I've been doing this for months now. Mark, we want to say thank you. I would say we can't give you a clap because there's only 3 of us here, but thank you very much. And we have time for questions at the end. So I thought maybe it would be better to just move on through all the talks. The questions are going to be given to me in the sort of comments box as they come in. And just to note that again to everybody, there is a comments box or a Q&A box where you can actually put in your questions, and we will address all of those at the end. Because I have a question for you, but I realize it might also go to Laura, so we'll see how that all pans out when we get to the end. So our second speaker today is Laura Bogart, and we've worked on a couple of projects together. So it's always nice to see her. She's a senior behavioral scientist at the RAND Corporation and a professor in the Pardee Rand Graduate School. She's a social psychologist with expertise in HIV disparities, including psychosocial factors in HIV prevention and adherence. Much of her research focuses on discrimination, stigma, and medical mistrust. And that is also the focus of the talk she's going to be giving us today. So if you'd like to share your slides, Laura, that would be great.
Yes. Are they shared?
No, they are now.
Okay, great. Great. So thank you very much for that introduction, and hello everybody. Thanks for the opportunity to present today. So I'll be discussing a pilot RCT to improve adherence through the mechanisms of medical mistrust and improved coping among HIV-positive Latinx sexual minority men. So I'd like to start with a conceptual model that underpins this work. So stigma, due to its intersectionalities of HIV and related intersectionalities like minority, race, ethnicity, sexual identity, poverty, are thought to lead to HIV inequities in prevention and treatment outcomes. And stigma can lead to inequities through a direct pathway, so through a physiological stress response that results in weathering and a cumulative effect over time on health. And what I'll be focused on today is an intervention around the psychological response to stigma and discrimination, including ineffective coping and medical mistrust. So ineffective coping with the stress of discrimination can lead to inequities through behaviors like sex risk, substance use, non-adherence to treatment, and healthcare avoidance. And also, I'd like to talk today about a specific form of coping, medical mistrust, which can be thought of as a form of coping with discrimination and conceptualized as an adaptive, functional coping response that helps individuals to maintain a sense of meaning, control, and empowerment in the face of discrimination. So it makes sense. It can be seen as a rational coping response that people put their guard up when they've experienced discrimination. But at the same time, we know that medical mistrust can also result in avoidance of healthcare. So the purpose of the intervention is to address ineffective coping as well as medical mistrust and in improving HIV outcomes. So I'll be presenting today the Siempre Seguiré intervention. This is a group-level, community-based CBT intervention to strengthen effective coping responses to intersectional stigma and discrimination and address medical mistrust among Latinx sexual minority men. And the name is loosely translated as I Will Always Continue. It's based on a popular song that's been seen as a message of empowerment and strength in gay communities. And this pilot study I'll be presenting today was focused on Latinx men living with HIV and focused on the outcome of adherence. So I'd like to start with an analogy because when I present this intervention in communities as well as academic circles, I've been asked, why are we asking the people who experience discrimination to change? Why aren't we changing the perpetrators, or why aren't we addressing the structures in society that lead to discrimination in the first place? So this burning building analogy is what we've used to talk about this issue, and this came from a community partner. So of course, reducing societal discrimination is the ultimate goal. But if a building's on fire, you don't leave the people in there when you put out the fire. So you both rescue the people and put out the fire, and also try to figure out why the fire started in the first place so we can prevent this from happening in the future. So that's what this intervention is trying to do. Trying to help people build resilience and empower them to cope better and lead healthy lives, but also keeping an eye towards changing parts of society that maintain oppression. So as you can see on this slide, there's a beautiful quote from Kareem Abdul-Jabbar that he wrote in an op-ed in the LA Times this year. And he also used this burning building analogy in talking about racism in America is like dust in the air, and we have to keep shining that light on it, and we have to stay vigilant. So I'll talk a bit about the intervention content and structure. So it's 8 group sessions using CBT, and participants learn adaptive ways to cope and resilience strategies from each other. So this is a key part of the intervention that we did not want it to be didactic. We did pilot work, qualitative work, showing that people do have these resilience strategies. They do have effective coping strategies. And one thing this intervention does is allows people to learn from each other and realize how they can generalize different coping strategies across different types of discrimination experiences. But we don't teach them specific coping strategies. We let them, we empower people to use these strategies they already have innately. And as I mentioned, it uses CBT to look at the CBT model, where we lead people through conducting a behavioral analysis of their thoughts, emotions, and behaviors in response to stigma and discrimination, so that they can be more mindful of the kinds of reactions they have and the coping responses that result. We also, in the last session, we empower participants to engage in structural change if they're motivated and if they want to do so. So we say, you know, you've gone through this intervention, people feel more empowered, and they have made internal changes, and they become empowered to want to make external changes and work within their communities. So we provide a resource list for them to do that. For example, local Black Lives Matter chapter, or Getting Out the Vote, or ACLU. So we tell them about different organizations they can volunteer to lead to structural change. And we also tell them, you know, we don't want this to just be something they do within session, that it's not just practicing within these group sessions, but actually going out into the real world. So we actually give them homework, and they need to report back every week on what they did. Did they change their behavior? Did their coping responses change? So we integrate intersectionality into this intervention. Participants discuss how multiple interlocking identities comprise their holistic sense of self. From the first session on, we give them an identity pie activity, which is essentially a circle on a piece of paper, and they need to put in all their salient identities into that circle and discuss them and how they all work together. And then we refer to that identity pie throughout the intervention. They also are encouraged to process how stigma and discrimination affect their whole identity rather than the separate components of it. So here's a graphic that illustrates exactly what we do in the intervention around the CBT model. So someone experiences an event and interprets it as discrimination, and then they have a coping response. So they might have internalized stigma, internalized thoughts like maybe I deserve to be treated like this. They might feel internalized stigma, shame, anger, fear, sadness. They might also display ineffective coping behaviors, such as displaying anger, walking away, concealing their identities related to HIV or sexual orientation, and then avoidance of people and places, which could be avoidance of healthcare, for example. So this is what the intervention tries to do. So there's an event and an interpretation that is discrimination. And then now people in the intervention learn this is something they need to be mindful of and think about their responses. It's one of those times they need to be careful about. So they have coping responses, but this time they might have more externalizing thoughts instead of internalizing and feeling badly about themselves. So this is about them. It's not my problem, it's theirs. They might have feelings more of self-compassion, self-acceptance, positive feelings about themselves. And finally, they may have effective coping behaviors like seeking social support. So I'll tell you a bit about the methods and how this was tested. So it was in the context of a community academic partnership between RAND and Bienestar Human Services in LA County, California. And Bienestar is a social and healthcare services agency with a primarily Latinx LGBTQ client base. We recruited via InReach in the agency and outreach to clinics and organizations in LA County. And they were eligible if they were Latinx, men who have sex with men. And also for adherence, we said they either had to not currently be on treatment but were prescribed it, or on treatment reported missing more than one dose in the past month, or had less than 2 HIV care visits in the past 12 months. We recruited 76 participants. This was a pilot, 38 intervention, and 38 waitlist control. So we did surveys at baseline, 5 and 7 month follow-up. We measured functional and dysfunctional coping with the brief cope and RCOPE. So the RCOPE is religious coping, positive and negative, modified for discrimination. So asked, what do you do in response to discrimination? What kinds of coping strategies do you use? We measured medical mistrust with the HIV conspiracy belief scale around the origins, mistrust around the origins and treatment of HIV. We used the internalized HIV stigma scale. For adherence, we used both MEMS, electronically monitored, percentage of prescribed doses taken, as well as a visual analog scale that was self-reported past month at each time point. We also did qualitative exit interviews with all the intervention participants to see acceptability of the intervention. So on average, participants were 53. 3/4 were Mexican ethnicity. About a third were citizens, about a third were undocumented, and relatively low SES. So about half not having a high school diploma, 80% not working, and 27% less than $5,000 annual income. And no characteristics here or other characteristics, sociodemographic and health characteristics differed between intervention and control at baseline. So first, in terms of results, we found feasibility. So high retention, 86% at 5 months, 84% at 7 months. And of the 38 participants randomized to the intervention, the mean number of sessions attended was over 6 of the 8. And among the 30 who attended at least one, so actually 8 did not attend any. And nearly all the reasons for missed sessions were unrelated to the intervention or study. For example, we had a lot of participants traveling out of the country, like to Mexico, or getting work, scheduling conflicts. Only 2 were related to the study. 1 was uncomfortable with the intervention content, and 1 had confidentiality concerns around his serostatus. So here are our results for adherence and just MEMS adherence. Just to orient you to the slide, this is percentage of doses taken, which is shown along the y-axis. Along the x-axis are number of months in the study, so from 0 to 7 months. From 0 to 1 to 1 to 2 months, that's on the left, that's the baseline measure of adherence pre-intervention. From 1 to 2 to then 4 to 5 months is the intervention period. And finally, the post-intervention is 4 to 5 to 6 to 7 months. So as you can see, the two lines, the black line is intervention, the orange reddish line is control. You can see the intervention slowly increases over time in adherence and peaks around 5 to 6 months, where the control participants mostly stable and maybe downward a little bit. But then both are about the same adherence by 6 to 7 months. So on average, the test showed that there was 99% higher average adherence in the intervention than the control arm, and this was a medium effect size. We also found results in the survey data in terms of increased self-reported adherence. That was a smaller effect size of 0.26, and decreased negative religious coping beliefs like feeling punished by God in response to discrimination, a medium effect, decreased medical mistrust in the form of decreased conspiracy beliefs and medium effect, and finally decreased internalized stigma. And we also found that participants really loved the intervention. They were very enthusiastic in the exit interviews. For example, the participant on the left said, "It was a beautiful experience. You realize you're not the only one. You know how to deal with situations." And the participant on the right, it was a very common sentiment that participants wanted more. They didn't want it to end. So I'd like there to be more sessions and more groups. So in sum, this is a promising intervention. It is a pilot. We're currently conducting a pilot feasibility and acceptability study to adapt the intervention for a virtual platform. And we are a bit concerned because we think that a lot of this intervention works through group cohesion and people really bonding and feeling like they're in a safe space. And we're trying to recreate that on Zoom or another virtual platform. And it may be a bit more difficult, but we're testing that out now. We also have 2 in-progress RCTs to test the effectiveness of the intervention on HIV prevention outcomes for Latinx sexual minority men. And also we're doing an RCT with general healthcare engagement for Black sexual minority men, regardless of serostatus. So the limitations of the pilot are small sample size. It's a convenient sample, primarily Mexican immigrants. And also individual level interventions are necessary, but they're not sufficient. As we know, they can empower individuals and provide resources and support to be change agents, but clearly we need interventions across multiple levels, including structural levels. So thanks so much. Just wanted to acknowledge the funding sources, NIMH, OIR, the great people at BNSTAR, and provide the reference in AIDS and behavior. Thank you.
Thank you, Laura, and a round of applause for you as well. We'll move straight on to Becky. Thank you both, Mark and Laura, for keeping to time. It'll give us some nice time for questions later. So, and I wanted to tell you, there were 237 abstracts submitted. So you're the top 3 of 237. So you can be proud. And just to introduce Becky Genberg, she's an associate professor in the Johns Hopkins Bloomberg School of Public Health and the Department of Epidemiology. She practices social epidemiology, focusing her research on the social determinants driving health behaviors and outcomes, and leveraging the methods of implementation science to examine multi-level influences of HIV treatment outcomes. And we're looking forward to hearing your talk. Thanks, Becky.
Sorry, I realized I was not unmuted.
We need to go into presentation mode, I think. Or is that? We're seeing your top 3 slides and this first one on the right as well.
Okay. How about now?
Perfect.
Good. Okay, great. Thank you so much for that introduction. Today I'll be presenting an analysis entitled Microfinance Participation is Associated with Retention in HIV Care Among People Living with HIV in Western Kenya. So I'm going to start with just a little bit of background. We have long known that economic factors influence HIV risk behaviors, and in fact, we now know they also impact HIV treatment outcomes at all stages of the HIV care continuum. This disproportionate burden of barriers for economically disadvantaged people living with HIV results in earlier disease progression, often because of the difficulties in engaging in HIV care along the way. Here I'm showing just a small clip from a paper by one of our colleagues in Western Kenya, outlining the barriers to engaging in care. And you can see that of the barriers among this patient population, many are economic in nature, whether they're at the individual, community, or health system level. Here I'm sharing a framework from FHI 360, which shows how economic strengthening interventions act on HIV treatment outcomes. And this is through bolstering financial resources to meet patient needs. This then improves patient food security and ability to pay for transport and other costs that might be associated with accessing healthcare. And this, of course, in turn improves retention and adherence to care. In a comprehensive review that Mandy Swan at FHI 360 published in 2018, there were positive trends noted for the impact of household economic strengthening interventions on adherence to ART and retention in HIV care, but the paper called for stronger designs to evaluate the role of economic strengthening interventions more generally. One specific model of this type of intervention is the group-based savings and loan model. This model involves participants pooling their savings and making loans to members of the groups for use on business expenses, educational expenses, or medical expenses, or just other improvements to their living conditions, and repayment of the loans with interest and then shared savings across the group. And you can see this depicted here in this diagram I'm sharing from Care International. This model is critically important for people living with HIV who are most often employed in the informal sector, and they have limited access, therefore, to traditional banking and financial services. But beyond the potential economic gains, these group-based interventions may also provide additional benefits, potentially through social support and reductions in HIV-related stigma, both of which influence engagement in HIV care. Given the lack of evidence cited in recent systematic reviews on these types of interventions, including one from our own group, we decided to conduct this study to determine the relationship between participation in a group-based microfinance intervention and HIV treatment outcomes. So our study objective was to characterize the relationship between participation in group-based microfinance and retention in HIV care and mortality among individuals enrolled in an HIV care program in Western Kenya. Our hypothesis was that patients who had participated in the group-based microfinance program would be more engaged in their HIV care and have reduced mortality compared to patients who did not participate in microfinance. So I'll quickly go through now the methods of our study. The study was nested within the academic model providing access to healthcare, which is a partnership between Moi University and Moi Teaching Referral Hospital in Kenya, and a consortium of North American institutions whose mission is to deliver care, train medical professionals, and advance research. Headquartered in Eldoret, Kenya, AMPATH provides HIV care to over 165,000 people living with HIV across 800 clinical sites. In full recognition of the challenges associated with the social and economic determinants of HIV treatment outcomes, AMPATH began GISE, or Group Integrated Savings for Empowerment Groups, in 2012. The members of GISE mobilize and manage their savings, provide interest-bearing loans to members of the group, and contribute to an emergency social fund. So our goal with the current study was to retrospectively evaluate this program. So our initial analysis included 1,787 patients who were alive and active in microfinance in 2018, and we matched them 3-to-1 to participants who were alive and not active in microfinance in 2018 using propensity score methods. We initially sought to examine the relationship between microfinance participation and ART initiation and retention, defined as having had a visit with a clinician within 180 days of database closure in February of 2019. We found a strong association between microfinance participation and ART initiation and retention in HIV care. And you can see those results here. However, we were concerned that the design was biased in that it was not accounting for the potential greater likelihood of survival among the microfinance group, since we could only define their participation in 2018. So what we did was we refined our analysis to more closely mimic what we would have seen had we conducted a randomized controlled trial. So what we did was we required patients to be 18 years of age or older in 2012 when the program was launched. We required patients to have been active in care in 2018, so not just active in microfinance. And we performed similar matching methods using propensity scores. And then we only included information on outcomes prospectively from 2018 forward through 2020. And we ignored any information on outcomes that might have occurred prior to that 2018 time point. Our outcomes of interest were retention in HIV care at 24 months, which again, we defined as having had at least one visit with a HIV care provider within the 6 months preceding the end of the follow-up period in February 2020. And death, which was determined from medical records data in the AMPATH medical records system. In terms of our analytic approach, we first looked at differences in sociodemographic and clinical characteristics comparing microfinance and control patients. And then we conducted logistic regression analysis for retention and death as of February 2020, adjusting for the matching variables as well as any additional factors known to be associated with retention and death in our patient population. So here are the sociodemographic characteristics of our sample. The total N was 3,609, with approximately 1,200 of those patients in microfinance actively in 2018 and 2,406 not in microfinance. 78% were female. The median age was 37 years. 90% had ever attended any school, and 15% had running water and electricity in their homes. There were no differences between the microfinance and control groups by any of the matching variables, giving us some confidence that our methods worked. And there were no differences also in educational attainment or WHO stage at baseline, and that was at enrollment in care for that patient. However, we did see that the microfinance patients were less likely than controls to report having to travel more than 2 hours to get to their clinic, and they were more likely to report that they did have electricity and running water in their homes. So here are some of the initial HIV treatment outcomes by group. You can see that as of February 2020, nearly 100% of our participants had initiated ART, with no differences here observed by group. And this really speaks to the success of universal treatment within the AMPATH program. Secondly, the groups were really well balanced in terms of the years in care and the years that they had been on ART. But you can see here that those who were in the microfinance group had a shorter time since their most recent visit at database close. They were more likely to be retained in care, therefore, at 24 months, and they were less likely to have died by 2020. So here are our findings adjusted by our matching variables as well as some additional variables. And you can see here that microfinance was associated with a 30% increase in retention and care at 24 months after adjustment. The 50% reduction that we observed in death associated with microfinance participation did not hold following our statistical adjustment, but it's possible that this was related to our short follow-up time and our relatively small numbers of death occurring in this 2-year period. Of course, we should always reflect on the limitations of our study in light of our findings. So the lack of randomization is not entirely handled by our study design, and that there may still be some unmeasured confounding that's not accounted for by the matching, which could then potentially bias our associations of microfinance participation, retention, and death. Due to the lack of systematic records available in the microfinance program, we were only able to measure active participation in 2018, rather than having a full accounting of their participation since 2012. And so we had to deal with this in our analytic approach, but we think that our refined approach addressed this limitation somewhat. We know that there is under-ascertainment of death in the AMRS, but this is likely not necessarily differential by the microfinance participation. Because we were dependent here on clinical data being collected, we had limited variables available for inclusion in our statistical models. And finally, there may be some concerns related to the generalizability of our findings. Taken together, we do think that the prospective findings confirm our initial retrospective analysis that suggests that microfinance participation improves retention in HIV care. Interventions such as microfinance that can address the complex socioeconomic drivers of vulnerability among people living with HIV may help us close the gap in achieving our UNAIDS 95-95-95 goals by 2030. And we think this is particularly relevant given the growing poverty and inequality we're seeing in sub-Saharan Africa, likely now being exacerbated by the COVID-19 pandemic and disruptions associated with the response. Finally, community-based models of engaging patients may be increasingly important as health systems expand to achieve HIV control targets and may be adaptable for decongesting clinics and expanding reach to patients in the community. So I'll just briefly touch then on future directions. Our active cluster randomized controlled trial called Harambee is designed to test the integration of HIV and NCD care with group-based microfinance to examine whether it improves viral suppression and retention in care among people living with HIV in this setting. And our study design should enable us to examine the mechanisms by which microfinance influences retention and viral suppression. So stay tuned for those results in probably about 3 years. I want to, of course, acknowledge the AMPATH patients and staff without whom none of this would be possible. I represent a very large team. This is actually just a small amount of them from AMPATH and Moy University, Johns Hopkins University. My co-PIs on the Harambee trial are Judy Washira and Omar Galarraga from Brown University. Special thanks to Jan Stigrensen and Joe Hogan for our statistical support, as well as the rest of the Harambee study team. This research is supported by the NIMH, and we acknowledge their generous funding. Thank you.
Great. Thank you, Becky. That's awesome. Very, very interesting. Right, now we have some questions. Well, I'm not sure if I haven't got any questions in the chat box yet, but I do have questions for all of you. So just for everyone listening, please remember to write in those questions because we've got a few minutes now to answer them. I'm going to ask Becky a question first because I really don't know a lot about microfinance, and so for me it would be a question of: is there like do you have like how you get this kind of thing going in a community, and is it more successful in a rural community or in an urban community? Sort of those kinds of, because I'm a very urban environment person, and it sounded like that may be a more rural setting.
Yeah, so predominantly our patients are coming from rural or semi-rural or even semi-urban settings, although my colleagues would probably tell me that Alderete is urban. I do think there is probably slightly more success for these types of programs in rural settings, but they are pretty ubiquitous across many different settings within Kenya. So I can't speak to exactly the level of success in one setting or another because our patient population is predominantly rural.
Okay, thank you. There's a question here actually from Jeffrey Dockery saying, what is group microfinance? Which I think might be just a review of one of the slides you gave early on. It feels, well, to me, it's like it's a really nice sort of trust system, which is a good topic for an adherence conference. But is there a definition for group microfinance?
Well, the definition we use to define group microfinance is that this is a group of patients who get together to pool savings. So they pay dues into the group regularly. That's often multiple times per year. And then with that pooled amount of money, they make loans across the members of the groups that come with a little bit of interest. And so when the member then pays back that loan with the interest, the savings or the income that is generated from that interest is shared across the groups. And so it's a way to kind of bolster individual household economic conditions through participation in this type of format, because most of our patients don't have access to loans from banks or other traditional systems, and they can use this to start businesses. They can use this to pay for expenses potentially related to education or medical expenses in their family, potentially bolster some agricultural expenses they may have to increase their food security, all kinds of things. And then there's an emergency fund, which they use mostly for catastrophic type health expenses or funerals and things like that, which they can borrow against within the group.
And a last question for you, Becky, from Marianne Onguja. What is the level of engagement of the participants in the microfinance programs? And she also asked, what's the amount of money in the savings group, to give some form of context?
So I can't speak to it exactly because it does vary quite a bit across all of the groups. There are thousands of groups participating at any time in the AMPATH program. So it varies pretty widely in terms of both how much patients do pay in and then how much they might receive out as a loan. In our analysis, active participation in microfinance just meant that when we went to pull the records on patients on who was participating in the program, that they had during the course of the calendar year at least met with their group one time, and so that they were included within the program with that definition.
Well, thank you. Very, very interesting. And there's a question for Laura from Jose Zuniga. In relation to medical mistrust, is there a need to look at implicit bias?
Well, thanks. That's a great question. When I talk about structural change, I mean, one of the changes should be interventions with providers, not just with patients, as I presented, and definitely interventions around reducing implicit bias among physicians, among providers, is really important at reducing medical mistrust. They're very linked. And doing interventions with providers to acknowledge medical mistrust, to talk about it openly, and also doing interventions with providers around implicit bias would be very helpful in this regard. But thanks.
And then I have a question for you as well. And it comes also from the work we did together with Ingrid Katz in South Africa, where we also looked at an 8-session motivational interviewing CBT product. And some of the criticism we've had when looking for future funding is the duration. You know, the number of sessions when you're trying to scale something up in a resource limited setting, which, I mean, I hear that your participants are also resource limited and restricted, but maybe you're less resource restricted as a healthcare provider. Was there a threshold for the number of sessions? Are you able to look at how many sessions you need? Is there a condensed version? Can we reshape it for another setting?
Yeah, I'm so glad you're asking that, because that is a criticism. A lot of this is how can this be sustained? So one thing that we think about is we're trying to make this an intervention that's completely done with the community, for the community, developed with community partners, so that it can fit into their existing structures for support groups. So they're already running these support groups that are every week. And the idea is that we have an intervention that we can train their peer facilitators to run the groups in the context of that. And so it's really more about the training of the facilitators and training them and taking the time, and then they can integrate these sessions into the group. If we did think about very hard whether we could shorten it, and we tried, but it seemed that participants kept asking for more sessions. We did try fewer sessions, participants wanted more, and we felt like we weren't covering all the material. So we've tried to think about this model of if we can fit it into the existing structures of existing support groups that are ongoing, it may work in that way.
Okay. Thank you. I also have a question for Mark, because I think it was me maybe understanding your feedback app. Essentially, I mean, when we're looking at, can your app pick up people who are poorly adherent to their PrEP early on? So the people in the red band at the bottom, do they identify them? Are they identified early so they can be picked up? So this is something, again, when I'm thinking about scale. We an app, we don't have the resources to do the sessions and the training, and then people need that interaction, that trust to be built with them, but we can't give that to everybody. So would your app allow us to pick up people who are struggling so we can focus our interventions there?
Yeah, thank you. It's the way we looked at the app right now, just reported the feedback to the participants themselves. So as healthcare providers, we did not directly get live updates from people who reported to be poorly adherent. But technically that would be possible. So in this trial, we didn't use that, but for future reference, it could be really interesting to also clinically implement that.
Yeah, good. Okay, thank you, everybody. Unless you have questions for each other, there's no more questions in the box. So it gives everybody 5 minutes to go and grab a cup of tea before the last session, particularly me. And we will be right back then at 8:30. I don't know, it's 8:30, 1:30 your time. Okay. Thank you all very much. Appreciate it.
Thank you.
Thank you.